Welcome back to the Spine Pod. We've been a little bit busy.
We have been busy. We got to sit down with Dr. Alan Daniels and Dr. Bassel Diebo at University Orthopedics in Providence, Rhode Island. And what a cool practice they've been able to build there.
I know. I loved the view. They've got essentially like a 360 view of the water. And it was a really cool place to get to record.
It's fantastic. And they're known as two complex spine surgeons, so doing large deformity cases. And it's interesting how much overlap there is with the work that they're doing and the work that we see in motion preservation. They talk a lot about sagittal alignment and sagittal balance. And those are all parameters that we look at with motion preservation. So it's really exciting to be able to sit down and talk with them.
I agree. I think sometimes we can silo those out, especially in the industry, and say, you're in one camp or another. And it's just not true, especially with how innovation is happening right now. Technology is moving forward. I think they were two really great surgeons to sit down with who really understand complex fusion and spine care and have an open understanding and eagerness to see motion preservation move forward.
Well, and just where it fits into their practice as well. I mean, between the two of them, almost 1,000 publications, another 1,000 podium presentations.
Insane.
So they're closely affiliated with the Warren Alpert School of Medicine at Brown University. Yep. And the work they're doing back and forth between those places is just phenomenal. But there's so much overlap. It was incredible to be able to sit down with them.
I agree. I think that for patients, this is a really good one to listen to really understand the complexities of why you're given the type of care that you are, or the type of surgeon that you should look for when you're only being given one option. Understanding why that sometimes happens and the questions you should ask.
Well, absolutely. And the concept of possibly inserting yourself sooner in the care continuum in spine care, which is something we haven't seen for a long, long time, but such a fascinating topic to be able to explore with two surgeons like that.
I agree. So enjoy this one with Dr. Alan Daniels and Bassel Diebo.
Dr. Daniels, Dr. Diebo, thank you so much for sitting down with us today.
Absolutely. Thanks for coming.
Yeah. I mean, it's gorgeous. You couldn't have picked a better day. You gave us some good weather to come out here. So
absolutely. Best time of the year in Rhode Island.
I think we worked hard for it, though.
Yeah.
Did you? What was the winter like?
Horrible.
Really?
Yeah.
Yes.
Long and cold.
So we picked the right time because that
100%.
view that you work with every day, I mean, that'll motivate you.
Absolutely.
Yeah, it's the winter is not a problem. The problem is the roller coaster the last 2 months where you feel you need to wear long sleeve and short sleeve throughout the day. Depends what the weather will be. So it was kind of interesting recently, but now it's stabilized at whatever it is right now. It's awesome.
Well, we'll enjoy it.
Yeah, we're fortunate. Well, thanks for hosting us here at University Orthopedics. Gorgeous practice out here in Rhode Island. And we appreciate you guys having us here. Really, we want to jump right in, hear a little bit about your guys' stories. Kind of what brought you to medicine. Dr. Daniels, you moved, West Coast to East Coast. That's a pretty long journey. Dr. Diebo, you came across the water. So a little bit longer journey, but I'd love to hear your guys' journey to medicine.
Yeah, I'll start with my story. It's a little simpler than Dr. Diebo. I grew up in Colorado, went out west, did my education and training on the West Coast, and then, like you said, I matched here for orthopedics in Rhode Island and just fell in love with the area and the practice. As you said, we're at University Orthopedics, which is a large private practice, but we work very closely with the academic department at Brown. And we teach within the department. It's just such a gem here in Rhode Island. Not only is it a nice place to live, but a great place to practice and to be able to innovate. And so for me, I was just drawn to the opportunity here of a private academic model. And I ended up with so many great partners like Bassel that I just could never leave. And so I've been very happy here.
Yeah, I moved east to west, but it was Middle East to west. I was just I was born and raised in Syria. I spent there for about 25 years. And then the war started earlier in around 2011. I was doing general surgery in Damascus at that time, and I thought it was a great idea to leave during the war. Nobody asked me why. And then I got a visa to the US, and then I came here. It was, as you come from a foreign country, you need to kind of do proper steps to, kind of equalize or neutralize your degree in medicine. And then from there, you need to apply to residency and do all of, everything over again. It's part of the process here where I guess the government just ensures people are actually educated enough to take care of humans. So I spent about 4 or 5 years in New York just doing spine research. That was before residency. And then at the time when I felt that my application is reasonable, I applied to residency, and I got into a Brooklyn-based residency program. So I spent another 5 in New York doing the residency program. And then I fell in love with spine the moment I landed in the US, because whomever helped me was actually a spine surgeon. So I hang out with him in Indiana, and he was an older guy. Still, he was like passionate about scoliosis and deformities and osteotomy cuts. So I loved it. And from there, I got the research job in New York, and I spent the following 10 years there. I wanted to be a spine surgeon, go into orthopedics, which often can be challenging. You agree? You go to orthopedic surgery, tell them you want to be a spine surgeon. It's not necessarily quite cool because, orthopedics is really trauma heavy, joints heavy, sports heavy. The spine folks are more or less an outsider. It's like, sit there. I want to do spine. It's all right, man. Okay, got it. You can do it. But I was very verbal about it. My research was very clear that I'm getting into orthopedics for spine. So, and then the fellowship time comes after residency, and then I applied to broadly around the country, and I chose to come to Alan's fellowship itself. I thought it was a great place. The same way he saw it, I saw it. I thought it was phenomenal. Great, kind of multiple pillars that are all excellent. The medical school is excellent, the healthcare is excellent, and the private practice is excellent. And there's a bit of a very healthy dynamic between them that allows you to be whomever you want without being restrained by institutions. And then I stayed on for faculty. So
yeah, I want to add a couple of things there about destiny. And Bassel's being humble, but he had people here that saw his amazing potential. And for whatever reason, he is destined to be a spine surgeon. A spine surgeon essentially sponsored him and brought him to the United States. Virginia Lafarge has been an amazing mentor to him, world famous researcher, and really took him under his wing like a mother or a sister or whatever family member. They're truly family. Dr. Paulino in Brooklyn really took him in to train him and said, I believe in you. I know you can do this. He's going to be great. And the two of them are very close to this day. And yet again, I saw him as someone with unbelievable potential. It's not like we've hired a lot of our former fellows. I mean, we train people all the time and we send them off. I said, this guy is truly special. We have to have him here. And so I truly believe it was his destiny to be here. It was meant to be. And both of us, I think, fell into spine surgery. And for whatever reason, I couldn't really see myself in any other career. It's like, I love it every day. I think about it every day. Excited to do this podcast and talk to you about spine. And for whatever reason, I mean, he and I talk 7 days a week, and we talk about spine, and we enjoy it. We don't see it as a burden to do this kind of work. It just feels that we're meant to be here, not only at this practice, but doing what we do.
I love that. That's kind of a through line we've seen through all of our podcasts. We pick people that we think are special and have something to say and share with patients and just anyone interested in spine. But everyone has said this story of there's kind of like, it's like a yellow brick road that you find yourself on, and it is a destiny. I loved that choice of words. And I'd like to hear a little bit more about that, if you will, of like the person you met and what that click was for you about spine, where, your experience in Syria and then coming here. Like, did you know anything or like have any interest in spine when you were there? Or was it really when you got to the US?
No, it's funny because in Syria, orthopedic surgeons don't do spine, only neurosurgeons.
Okay.
And I went back and forth on that because in medical school, I really liked orthopedic surgery, but I never got orthopedic surgery residency. The reason I liked spine when I got here, again, it was really a destiny, but I love the biomechanical aspect of it. I love the way that we need to understand how to shape things for them to be better. And that's pretty much applies to a lot of orthopedic concepts. But spine in particular, it's also really hard. It's not easy. It comes after you. As Alan said, it's really easy to sit down and say, "Oh God, this it's a hard case. It's like I don't know what happened. This complication rate is high. Patients, we're still learning in spine. The innovation in spine is so vast that I found a room. I found a room for myself, and I loved it. At that time, the surgeon that Alan mentioned he was now it's a surgical planning software basically that was innovated by Virginie, my mentor. He was user of it. So I used to plan his osteotomies with triangular cuts and simulate the plan. And so I was always fascinated that we can really look at it, change the shape theoretically, and then execute it. And the execution was hard. That's the hardest part of it because you do it, we have a lot of models, a lot of softwares we use. Sure, SPO 5 degrees at 1, 2, and then you get in there, it's like, so
not really moving.
And that's this aspect. I don't think surgeons talk about it enough. They kind of shy away from it. It was like, I don't know why this failed, but if you look at what you wanted to execute and what you executed, they are not the same. And intraoperative verification of plans is extremely important, and we fell into that as well in our research aspect. So we love planning. We love making sure that we executed a plan, and we do way too many X-rays just to make sure in the OR that we got why we were there for. We were there to execute a specific plan. So that's what drew me into it. It's just very satisfying.
So obviously we're generally geared toward motion preservation. So most of the guys we have on are doing a lot of that work. You guys do a lot of adult spinal deformity and big complex cases, right? And I think a lot of people would say those two things don't live together. But I think the truth of the matter is they live together more than anyone can think. And there's a reason we're sitting down here, right? So you talk about kind of your journey through spine. You've had 3 research fellowships, right? You went to NYU, you went to HSS, you went to SUNY Downstate. I mean, you have been through everything. Now you're the director of spine research and innovation here as your first year into practice. I mean, that's no small feat. And then Dr. Daniels, you're here, the chief of spine surgery at University Orthopedics, right? And I think that part of innovation in spine research is really what I want to jump into is the work that you guys are doing. And specifically, I think you guys do a lot of work in balance and alignment. And those are 2 big concepts that I think there's a lot of convergence, and why you guys drive towards that, or why it's such an important topic that people need to know about in spine.
Yeah, I'll start there to say that we talked a lot about our background in orthopedics. Orthopedics is all about alignment, and it's about function, and it's about restoration of motion. And so I think that you're spot on when you say that they really do align well, that with the current technology we have and with many of the patients we get that are kind of, I'll call it end-stage disease, they have to be realigned. It takes a lot of destabilization and then stabilization to pull the patient into where they need to be. I think a much more optimal situation for these patients is to get to them earlier when possible, and then restore alignment and motion with something like arthroplasty or, motion preservation devices. I think just because he and I tend to, in our practices, fuse people's spines, stop motion, doesn't mean we're not huge believers in maintaining, restoring alignment. And we have partners in our practice that we will refer to that need arthroplasty. But we tend to specialize in the, reconstruction of end-stage disease. So I agree. I think we're absolutely fully aligned.
Yeah, what I think is that the solution to spine conditions has been forever to fuse, and to fuse you need to choose a shape to fuse the patient to that shape. That shape is often, for decades, we've been planning the standing shape. You are because people need to not fall; they need to be well aligned in standing, because standing is what this is like they used to say. Alignment is balance in motion. So the only way you can function on a daily basis if you're not falling when you walk. Now, so we need to give them a standing alignment. Now we're sitting. The sitting alignment is different. The unfused segments behave differently in sitting, and that's the problems we're facing for many decades now. Is proximal junctional kyphosis. Obviously, let's say you do a T10 pelvis. You control that. You shape it the way you want. Let's say you're the master of intraoperative execution, but then the patient want to sit like me right now, and everything above T10 is in kyphosis. It's in flexion. I'm watching TV. I'm going to look up or go garden or do something. There's a lot of flexion activities. Fusion is not friendly to flexion activities. Actually, I visited a lot of surgeons recently, just out of a fellowship program after I started my practice, and a lot of them actually prevent people ever from picking up something from the floor forever. They just use a little pickup or something like that, which is they're trying to maintain the longevity of the construct. So I think that's when motion preservation comes in, where if you can come up with a way to establish a hybrid construct, we've been doing that a lot, where we establish the foundation of the spine and lumbar spine, the shape we want. It's the human shape, right? It's a curvature that's called lordosis. You have to restore it. And then everything above that need to be flexible, because that's where the other daily activities occur. We started doing a lot of ligament augmentation for that. For example, we thought that if you can stop as short as possible your instrumentation and fusion, everything above that could be 3-level or 4-level. You can do some ligament augmentation, kind of reestablish this interspinous ligament, but with some give. This way, the patient will kind of come pick up something from the floor, but they spring back to the alignment they need. Obviously, it's a very primitive way of motion preservation, but this is where I think science is going.
Yeah, that's what I was going to say. Is we really are in a bit of the dark ages still in spine, which is crazy in 2024, because you're never going to fuse someone's hip or knee. Basically, extremely rare. And really, the optimal is to say, oh, well, even if the spine is deformed, such as if you have a varus or valgus knee, you still replace it. Ideally, long-term, you would replace the spine with some sort of optimal shape and flexibility.
I love some of the concepts that you guys talk about too, about kind of this hybrid approach, and that's what we see when you talk about, PJK or these other concepts, on a smaller scale too, just adjacent segment disease in general, right? So you get some of these just hyperphysiologic loads at adjacent levels in some of these instances, and working to have hybrid constructs or whatever that is, I think is a step, in the right direction, or whatever we can do to aid in those things. One of the things that I find is really interesting is how we measure success in spine, right? And like one of these concepts is we are in the primitive ages in spine, or have been for a long time. And I think through a lot of the research that's being done, we're catching up. But what are the metrics that you're looking at to measure success? Are you looking at, are those radiographic success points? Are we looking at PROMs? Like what are we measuring? And then the question is, are we measuring the right variables on what success should look like in spine outcomes?
Yeah, I'll tell a little anecdote. We laugh, me and my PAs, because one of my PAs likes to say that, the patients with the ugliest x-rays come in and are doing the best often, because we'll see the x-ray before the patient comes in the office, and I go, ooh, oh boy. And we walk in, they say, oh, Dr. Daniels, you're the greatest. I can't believe it. I feel so great. So just looking at the radiographs alone is not enough. So I'll let Bassel comment on all the ways that we measure success, but clearly radiographic success is not sufficient. But also just asking the patient, are you happy? Did you do well? Really may not be enough either, because in spine especially, you'd comment on adjacent segment disease. You may have a patient who comes in at 6 weeks, they just love you, they're doing great. You're starting to see something on the x-rays, something's coming. They may come back 3 to 6 months, still doing great, but you kind of know this isn't going to go well. And by the time a year rolls around, they're getting a revision. In no surgical specialty is a revision within a year optimal or reasonable or really acceptable. Even if it's the natural history, it'd be nice if we can find a way to stop it. So we have a lot of other ways to measure success, and we'll let Bassel chime in on that.
Yeah, it's been a lot of efforts and debates about how to measure success. The old-fashioned way, not old-fashioned, but we started with making sure that we know what parameters on the x-rays are correlated with success. And then we used to, or we still give patient-reported outcomes. Basically, patient will fill questionnaires about their lives. But then we noticed that there's kind of discrepancy between the way they objectively move and the way they subjectively score. So we started doing like some gait analysis, some functional assessments, and we published on Dubochet functional test just about 3-4 years ago. Basically, a battery of 4 tests where you ask patients to do certain things, getting up from unarmed chair, walk 5 meters back and forth, dual tasking test, down and sitting test. So we start scoring the time the patients need to perform those tests before and after surgery. And then now we're part of the trial with Ram Haddas. Basically, he's an engineer from he was in Texas back now, University of Rochester. He came up with a device that you put in the patient neck in the back, and it records their activities for 3 weeks, I believe, without it kind of gets stick in there. So you can do 3 weeks post-op, their cadence, walking speed, and the amount of time they slept, they walked, basically record them. And this way you objectively can tell if they got better or not. But the other angle to look at it is like success is really satisfying why the patients had surgery. I think it's as simple as that. And patient-generated index is one of the UCSF Chris Ames attempts many years ago. Touch on that. Basically, ask the patients why they're having surgery or why they want to be treated. Are they want to play soccer? They want to play golf? They want to play with their grandchildren? They want to ski? It depends why they are having the surgery. And if they achieve that goal, it's a successful surgery, no matter what you say, basically, because that's why they had it. You know, it's buying a car, buying furniture. You love it, then that's why that's success. It was worth it.
That's right.
So if you understand why patients are having what they having, then success is satisfying those, I think.
So I know you guys are very focused on the importance between not just the spine itself, but the body as a whole, right? And it's funny, Dr. Daniels, I saw one of your posts on LinkedIn and someone had asked, well, isn't there more, because we call it hip spine syndrome, right? And you said, well, if I could call it hip, spine, pelvis, knee, ankle syndrome would be great, but that doesn't sound as good coming out. So I want you guys to talk a little bit about the complexities of that and the importance of looking at all the other joints as a whole when you are treating a spine patient.
Yeah, as our background in orthopedics, we spent our lives studying all the different joints and ways that the spine interacts with, as you said, the pelvis, the hips, the knees, the ankles. But really what we've done is we're getting full body imaging on all the patients, which has been a total game changer to understand how not only the alignment, but the motion above and below is affected by spinal deformities or even optimal spinal alignment. And so I think for us, being able to image the hips, the knees, the ankles, the cervical spine, when you see a patient with a lumbar disorder, you learn a tremendous amount about how they're compensating. And it's really changed the way that we understand and treat these patients.
Yeah, I agree. I think looking at the patient as a whole was always easy to say, but hard to do. I think, the way we're trained in orthopedics is very x-rays heavy. So I always kind of want to laugh when I say it was like, oh, we were so fascinated by EOS and the full body x-rays. And I love it. I've seen thousands of them and we did a lot of work. We love it. And we still do that. But in mine, I was like, well, you have the patient walking too. So you can look at them.
Just look at them.
Right. And now me and Alan start having like actually a system where we record the patients. Every patient having surgery, have an interview with our assistant. And they actually get recorded walking back and forth before and after. So looking at the patient as a whole is really important. And just a couple decades ago, we were just looking at a short lumbar film with half sacrum, basically, no femoral heads. And we were like, we don't know what we're failing. Now, I mean, if you have a hip flexion contracture, if you have a severe knee arthritis, varus knee, Alan, you showed me your case with the patient with the meniscal injury. And they were totally messed up global alignment. If you look at it, I was like, this need a T4 pelvis, man. This is like so severe deformity. And then she got a scope.
She had a knee scope. She fixed it.
She came back with an EOS like,
right? Because her knee was hurting. She's flexing her knee. She's leaning over into the knee. And if you just look at a Scoli film, it looks like her spine is off. In reality, she's compensating for the knee. So, it's been very instructive to have full body radiographs.
Yeah, for us, it's very, very important. We spend tremendous effort before surgery. I mean, that's the key, because the more you think about it, the more you find things to make them better, optimize things, make sure. Sometimes, now us and the hip or the knee surgeons are in constant communication. I mean, I just had a patient this is a story for you. So I had a patient, severe scoliosis, severe sagittal plane deformity, multi-level spondylolisthesis, pelvic tilt, on the higher side, and bone-on-bone hip arthritis. She's there. She was, Dr. Diebo, back pain, hip pain. And I was looking at it. I was like, listen, I really think it's coming from your hip. We're gonna start with the hip because the pelvic tilt wasn't too high. So I didn't think the cup position will change if I do surgery after the hip surgery. So she went to Valento. He's the chief of hip and knees for us. He did her hip just 4 weeks ago. She just saw me yesterday in the office. I was like, so when were we doing the scoli? We got a physical scoliosis. She was like, I mean, I feel great. My back is good. I was like, well, okay. So the way the hip was ankylosed or fused or autofused, in the sagittal plane was affecting the need for lumbar compensation. So she had to extend her lumbar spine because she was so forward from the hip. When he released the hip and the arthritis, she is not compensating in the lumbar spine anymore. So she's standing comfortably. She's not stressing the neuroforamen. She's not in pain. So, I mean, that was virtually not possible if there's no, full understanding of the whole axis. So it's not a theoretical thing. It's a real thing. And patients deserve from us to know everything about them if we're talking about reshaping their backs. So that's why we like full body.
It makes me think a lot. I think in medicine, sometimes we do things in boxes. There's lots of silos. And as a patient, that can be frustrating, right? Because you're like, well, I don't know, and I'm coming to you. But if you only look at me in this small box, there's a lot that's missed on the outside. Can you talk a little bit about what those types of conversations are with your patients? So for those patients who are listening, maybe they can figure out how to have those conversations with their providers as well.
Yeah, that's a great point. A lot of patients are educated enough to tell you, hey, listen, I have a stenton, or I have some other device in my body, or I have this condition. Please make sure to communicate with my provider for that. So some of them are educated enough to know this. But in general, it is kind of sad that medicine is very fragmented, and a lot of it is job security. A lot of it, the extent of training that's needed to produce somebody that's perfect in one topic. We try to connect a lot with others. I mean, we have a bone health program for osteoporosis. We have hips and knees and foot and ankle and peds in the same building. The physical therapist is here. We have a nutritionist. We have neuropsychologist, neurologist. We communicate with a lot of them, movement disorders. So we try to build a network that take care of actually a musculoskeletal condition with some neuromuscular flavor or some sarcopenia flavor or osteoporosis. So it is hard. It's on us actually to build this network. I think every condition needs a multidisciplinary approach. It's identifiable. You can tell, to take care of a spinal deformity, for example, you need about 4 or 5 specialties. And those, if everybody's on the same page, you should be okay. But otherwise, it's really difficult.
It's hard. It's American healthcare is very fragmented. It's very difficult. And, we're here in University Orthopedics, so the orthopedists, we're very connected. We're in the same building. I say, hey, let me go talk to the joints guy 1 second. And I do that all the time. I did it today. But, patients do have to be empowered. They get bounced around a lot. I saw a lady today who had piriformis syndrome, and she had been to like 5 specialists. It was very frustrating. And unfortunately, her visit with me, I don't operate on piriformis syndrome. I had to send her to one other doctor. We finally made the diagnosis, but I advised her. I said, now that you know your diagnosis, you'll have to be empowered to really, take this on herself, figure out who can treat her and take care of her. So you're right, you're spot on. It's tough. But the good news is, in spinal deformity anyway, we've really figured it out. We've built the team. Someone comes in with a diagnosis, we say, you need to see this doctor and this specialist and this person. We're going to get you ready for surgery. For people with a lot of conditions, it can be tough, Ehlers-Danlos and some other things where they say, I'm bouncing around to specialists. Difficult.
Yeah, it's tough. I mean, I got another example with a patient that she is a mom of 7. And eventually at the seventh delivery, the pubic symphysis subluxated a little bit. It widens and sometimes it glows back down. We've seen it a lot in residency and training. But for her, because she subluxed and went back multiple times, she started having arthritis of the pubic symphysis. It's like you look at it, it's like, maybe I've seen it 3 times in my life.
Unusual
I have to say, how rare is that?
Right.
Very.
And then at the same time, she's got a sacro SI joint pain. I was like, all right, so she got a front problem. It's a ring. A front problem, a sacroiliac joint problem. And she's been bounced around people. They were basically laughing. I was like, dude, pubic symphysis. It's not even a joint. So it took me to call one of the interventionalists, tell him we need a diagnostic SI joint injection. I spoke to the traumatologist, Andy Evans. I was like, have you fused a pubic symphysis before for arthritis? He's a like level 1 traumatologist. He does like pelvic rim fractures and stuff like that. He was like, I need the flamingo view. I was like, okay. So flamingo view, you stand on one leg and you see if the pubic symphysis kind of sublux from each other. I was like, I'll get you that. I got him that. It was a really 3-4 specialists to see how we can help her. SI joint injection worked. Evans saw her and was like, this is a clear subluxation of this, of symphysis, has arthritis in it. So she needs a fusion in the front and a fusion in the SI joint to stabilize the entire pelvis, because she feels that she's off. Every time she stands, she goes, boop, 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 boop. It clicks and subluxes. So sometimes, you're right. If there's no communication between us as providers, patient, it's very complex for us, let alone the patient themselves. They can describe it as pain.
Right.
My hip hurt. It could be hip, could be sacroiliac joint, it could be a lower lumbar spine, it could be piriformis, it could be gluteus, it could be bursa. Go figure. So I think it's complex. It's on us.
Are you seeing patients that are coming in on the topic that you just talked about? Are you seeing patients that are coming in more informed now? Because, we've got this access to information that we didn't have 10 years ago and 15 years ago, where patients are coming in and we're hearing more and more stories of patients coming in and not asking like, oh, what's wrong? But saying, here's what I'm looking for, right? I'm like either looking for this device or this type of surgery or, this technology. Are you guys seeing this in your practice as well?
Yeah, absolutely. The short answer is yes. There's no question. People are much more informed. They can just go right online and read tremendous amounts about their condition. With that being said, at least locally, I can tell you, a lot of people still just want to hear what the doctor has to say, and they really say whatever you think is best. And I think this is a topic that's very pertinent to motion preservation, arthroplasty, and spine. There's certain markets in this country, in Southern California, in New York, and a few other places, Chicago, patients say, I want an arthroplasty. I want to go to the best arthroplasty doctor. For whatever reason, there are other places where the patients really seem to trust their doctor. They go in and they just say, whatever you think is best, doc. And I think over time, my guess is more and more patients in markets around the country and around the world will ask for arthroplasty or for maybe robotic spine surgery or minimally invasive spine surgery. But patients are informed. And I think as we get better at informing them, because part of it's our job to educate them, they'll come asking for the most optimal treatment.
Yeah, I agree. I think patients have a lot more resources today for the information. I mean, Alan you've probably got 3 patients from Texas from LinkedIn,
yeah.
right?
Yeah.
Patients look things up. I mean, it's funny you asked, because 2 weeks ago I was in a patient. She's young, in the 40s or so, and I was telling, I was kind of talking to her about ACDF, anterior cervical disc and fusion. And she was like, oh, yeah, you mean this? And then she showed me a TikTok video by Chester Conlon.
Yeah,
oh, you mean this?
Of course. Yeah.
See,
I was like, yes, I mean this. So they can look things up. And there are sources in ChatGPT. I mean, give him a knife, dude. I mean, he'll be a surgeon, So there's a lot of resources. If you think about it, just a few years ago, patients, had to watch TV or read billboards or do something to know. Today, if they are connected to the internet, they know, and that's good. It's good in a way that they are informed in a way, but also there are some resources of information that are super questionable.
Well, you guys have a great article that you actually published on the subspecialty of, in general, when you look at orthopedics, I think it's, 87% of residents in orthopedics say that they're going to go into fellowship. And I think there are only two other specialties that are above 50% of residents who say that they're going to go on to fellowship. I think it's general surgery and ophthalmology. Do you see that being a trend? And what's the importance of that, to your exact point of whether it's a deformity case or someone looking for an arthroplasty, finding someone that's specialized? Because I think we're starting to see that of these centers that are popping up, whether it's for arthroplasty or motion preservation or deformity, where you're finding guys who don't do 3 of them a year, right? If you have a big complex deformity, you don't want to go to somebody who's like, oh, I do 3 of these a year, right? You want to go to someone who does the research that you guys do. I think you said you did over 100 publications just last year from out of your guys' lab. I mean, that's incredible, right? So you want to go to the people that are doing the most research. And what's the importance of, finding those specialists that are doing those operations?
Sub-specialization is extremely important. I mean, that's why Giannis doesn't play soccer, right? But me and Alan believe in scaling knowledge, though. Meaning, if we do a reasonable job, there's a 5,000 to 6,000 spine surgeons in the country. If we can share information and learn from each other to a certain degree, where we ensure a certain level of service to the patients, worldwide or US wide, I think that's very, very important. Now, of course, if you're having an arthroplasty and you give somebody give you 2 options, you have Diebo who have done 2 in the past 3 years, you have Daniels who have done 300, you know where you're gonna go. It's just muscle, muscle memory, right? But at the same time, there are some people and patients in the country that don't have access to that. I think some certain procedures should be saved to tertiary sub-specialized centers, which is okay. I mean, cancer the same way.
Absolutely.
MD Anderson,
100%.
Memorial. If you have cancer, there's 3 places you go to. You don't go to the deli down the street.
And it's if you have a rare cancer, though. That's the thing, is if you have a very, very common cancer, you can be treated in that small community center in Nebraska, which is very reasonable. But if you have the 1 in a million, there's only 10 in the country, you got to go to one of those centers.
Yep.
And that may be the same in spine.
Yep, I 100% agree.
When we think about, we've talked about this too, of like all the joints in our body, the spine's the most complex one, right? There's so much going on.
We think it is.
I think it's pubic symphysis.
We did learn this today, didn't we?
Yeah.
There is one thing that I want to talk about, since you guys are both so prominent in research. You're both part of ISSG, right? International Spine Study Group, putting out tons of publications. I think over 30 podium presentations last year for your guys' lab, $1 million in grants. What are you guys working on right now? Or, spine is changing so fast. What is on the leading edge? What are you guys working on that you're really excited about for kind of that next stage, or what's coming for improving spine care?
I think the most important mission in the past year was trying to make spine surgery more reproducible by standardizing targets for segmental lordosis. I think we took this on. We really wanted to scale it. We published and in process of verifying it with data, segmental lordosis targets. Basically, if you're doing a 1-level case, if you're doing a 2-level case, if you're doing a T10 pelvis, if you're doing a 1-level fusion, if you're doing an arthroplasty, if you're doing anything on an L4, L5 for a pelvic incidence of 50, it has to be the same target, because that's the spinal shape of that human beings with a pelvic incidence of 50. There's, in my hand, the way I do it, the way I approach it, it can be whatever. But if you standardize the goal, then we should drop that variable at least. And when we look back why things fail, it's easier to identify why they failed, because we all shot for the same target, right? We give you a ball, shoot on that. You hit the target. You don't hit. It's clear why we failed. We didn't hit the target. So we really wanted to scale that. And we wanted to scale it 360. So we trying to make spine surgery more reproducible is the first innovative aspect that we're trying to work on. I would say that. And then the soft landing and the PJK tethering is really one of our favorites. We've been working on that a lot.
I would say also optimizing the length of fusion. And by optimizing, I mean minimizing the number of levels fused. I think that's another area we've looked at a lot, is the upper instrumented vertebra and lower instrumented vertebra is really trying to do the shortest fusion possible. But to do that, you have to get back to Bassel's first point, which is optimizing alignment. You've got to nail the alignment. One of the problems with deformity long-term is the surgeons would do, like he had talked about, a T10 to pelvis fusion or a T4 to pelvis. The alignment within that construct may not be that important. It's almost like doing a Harrington rod. I mean, it's not that simple, but the idea is if you can put the top above the bottom, it's probably okay. But if you fuse short, you better nail it right, because otherwise it's going to fail above it. And so they all tie together.
Yeah. And then I think the intraoperative execution verification and basically making sure that you A, plan, B, transition your plan to the OR, C, make sure they executed it in OR, and then D, try to follow up and make sure you executed that or you succeeded. I think that's very important.
And this is the opportunity for industry and for you guys, whether it's arthroplasty or some sort of replacement or a fusion, long term, it's going to be giving the surgeons tools so that they can execute in a reliable manner and tools to assess intraoperatively. And I think those are going to be partnerships with industry that we have to take. The current tools we have are good, but the current, TLIF cage is just maybe not there enough to get that alignment how you need it. And same with some of the arthroplasty devices. I think they're good, but we need to see another generation that comes from the data we've created, the ideal segmental targets. How to achieve those segmental targets, I think will take time, and honestly probably will take us a good part of the rest of our career to try to figure out how to put that in surgeons' hands all around the world and see if they can deliver it. Because the current tools are good, but not great.
Yeah, I agree. I think if you look at the way I would love to see things before I retire, is if a 1-level fusion has the longevity of a total hip, and a T10 pelvis has a longevity of a total knee. Then spine surgery will be.
But should it be a one-level fusion? Do you think that?
Not necessarily.
That's the question, right? Like, where does motion come in there? Is that really what we're looking for of like, is fusion the thing we should continue to innovate on? Or should we as an industry continue to look for other opportunities to replicate the spine in a more natural way?
Every time I think about arthroplasty and talk about it, it reminds me with one thing Frank Schwab used to say. He used to say, I think we need a solution to meet the disease halfway. And that's, tying to Alan end-stage disease. But if you see an L4, L5, and because of segmental lordosis, we know exactly when a segment start falling short in terms of alignment and derangement. If I look, and I just saw really 3 patients last week, one level disease, and one level fusion was a misnomer, just because I fused, so it's a one level disease. Let's say one level disease. If you look at the one level disease, L4, L5, you are 43 years old, and you have an L3, L4 hyperextended compensating for L4, L5 that's failing. L5S1 trying to lean down because now it's also under pressure biomechanically. And you have a solution, and it's 100% going to be arthroplasty. I think it's 100% because if you meet the disease at this stage, you could reverse natural history by maintaining what its functionality is, at the same time restoring the segmental lordosis. I think this is when we buy patients way less deformity operations, and I'm fine with that.
So let me ask you a question then, Bassel. In total hip and knee, you can have the most destroyed knee and hip you've ever seen, and they still can cut it out and replace it in almost all instances. Very rare you'd have something so severe like, oh my gosh, I need to fuse this. How come the spine's different?
Well, you mentioned that. You mentioned some of that, the neural elements, the vascularity around it. But that being said, yeah, if you today tell me, Bassel, here is a jig, you place it on the spine, it will make bone cuts, and then you slide in your implants, and they replace the whole spine. All right, give it to me.
Yeah, that's what I'm getting at, is I think part of it's probably the limitations and tools that we have. I think maybe with robotics in the future, that will be possible. What's amazing is that innovation's coming slowly. And in spine, I took a lot of trauma call early in my career, and all the spinal cord injury patients, the question is always, what's in the pipeline? Is this, I'm young, these people will come in teens and 20s, spinal cord injury. What's in the pipeline? There must be studies going on. And I go, not soon. And amazingly, I think for true high quality motion preservation of those really destroyed discs, it's not soon. It is eventually. But I think for the discs that Bassel just talked about, the meet halfway disc, absolutely 100% arthroplasty is going to be a huge part of spine practice in the following decades.
Well, I don't think there could be a better way to bring it full circle, because I think the truth of the matter is all of these things are coming together, right? We've had, it's this stepwise process, and we had disc replacements, then we learn on what works and what doesn't, right? And now we're working towards arthroplasty. And to your point, if you've got multi-level degen in these huge cases, or not even degen, just these spinal deformity cases, right? There's still going to be an in-between where all of these things come together, right? Maybe you shorten a segment and you do below and above, right? To protect against some of this ASD. I think all these things are going to come together, but it's going to become easier when we have the right nav, when we have the right robotics. And to your point, the execution becomes that easy, where you're not waiting and saying, well, this guy can perform it at this level and this guy is completely different. That's what we're trying to do, right? Is kind of level the playing field. And I think a lot of the research, all of these things are coming together and going to work together to provide, better spine care in the future.
I think eventually, though, it's like interest, right? If you, at least for sagittal plane deformity or iatrogenic cases or one level spondies, if you make those not progress into a deformity case, then you're taken away from deformity practices, which is okay from business standpoint. But taken away from deformity conditions and put it in the degen world, fix it in the degen world, keep it as a degen case, and all of a sudden you have 80% of spine patients. Deformity is not that common. We did a lot of market study. 60-70% of the market is degen. It's 1 or 2 levels. And if you make an arthroplasty solution to those that make it 15 or 20 years shelf life, this is phenomenal. Like that 100% should be there. And I think it's closer to what we think. I think it's closer in time.
We think so.
I know you guys know that.
And I think the biggest piece is that the last point that you just made is how do we turn some of this into preventative medicine versus retrospective treatment of things that we have pushed off for a long, long time. And I think we're close and we're getting there, and they continue to happen through research and all these other
absolutely.
aspects.
I mean, we looked at the ISSG data. 52% of the cases were revision cases that could have been prevented from the degen world. So meaning degen world need a lot of innovation and new solutions, and arthroplasty is a big deal. If you save those 50% of the population, I mean, I just did a Scoli case, right? It's 42 years old, really stiff scoliosis. This is not your problem because this is hard. I mean, I did osteotomies and still doesn't rotate. You're not going to put arthroplasty there, which is fine. Fusion is a true and tested for a lot of those cases. But this 1 level or 2 level degen cases, even some of degenerative scoliosis cases that are lumbar or lumbosacral, that could be. I mean, where arthroplasty could work. And I think solving sitting is a big deal for arthroplasty. Sitting is where the proximal lordosis wanted to be kyphotic, and if you are fused and you kind of sit in a standing posture, that's a problem. So I think there's a lot of application for arthroplasty. I'm not too worried about the complex deformity case. I'm worried about the ones, the multiple ones before that.
And we say that a lot of there's a place for fusion always, right? But there's also so much opportunity where there could be options that are motion preserving to allow those patients at 1-2 levels to be able to have that motion back. And I think that's worth investing in, right? And looking into, because as you keep saying, when you're sitting, like you want to be able to sit, and we're a sitting society now.
Mm-hmm.
We all spend the majority. I mean, you guys don't because you're standing up doing surgery, but like I'm sitting all day long. We spend majority of our time sitting now. There's a saying like sitting is the new smoking. And I think that it's true. And so that starts to shift. 50 years ago, that was not the case. And so also fusion made a lot more sense then too, of like, how do we also shift with how society is shifting? We need more options. We need innovation in order to meet that.
Yeah, it's 100%. I think the fusion is there for this degenerated facets, really lateral subluxation, rotary subluxation. Fusion, it has its own patients, but arthroplasty has to come play in. I mean, if you think about it, most of stiffness is a concept that hip surgeons are really obsessed about. The stiffness of the lumbosacral junction is a problem for them. Because if you take it away, then rising from a chair is a problem. Then the lumbosacral junction is stiff, and your femur will move more than the lumbar spine when you sit. So it goes and flexes higher. This way, your implant could impinge because you moved this kind of sitting dynamic from being a lumbar base to being a femur base. It's a bit complex, but what I'm trying to say here, if you preserve some of the flexibility of the lumbar spine, you could prevent a lot of dislocations technically in the
Yeah, 100%. I think if I look back on my career, 20 years from now, I think I'll be a bit upset about how many people we fused. I mean, I think just yesterday did a fusion. Basically, the indication was above a previous fusion, alignment's not perfect, and I had to do a very wide decompression, very severe stenosis. And this was upper lumbar spine, 1 level. There's no reason that shouldn't be an arthroplasty. There's no listhesis. There's no inherent true major deformity. Slight sagittal plane, I'll call it malalignment, but even for me, someone who's obsessed with alignment, I'm not quite sure where they need to be. They're fused below. To allow that patient to auto-regulate with a motion-preserving device would be optimal. If I had to guess, we'll look back and just say, I can't believe I fused all those people. But that's where we're at with the technology now. And in all fairness, that guy will do well. But it may not be the most optimal treatment for him because of the stiffness that we talked about and because of long-term ramifications of stiffening the spine.
Yeah, it's fascinating how many times, I mean, you live longer, right? I spent 1 decade in spine so far, and I look back at 1 decade ago, research topics and the ways we've done this is like it's a joke, but then it's part of progress. I'm proud of that too.
Yeah.
If I am exactly what I'm doing 10 years ago, it's a problem, right? So that's where arthroplasty should take us. Should take us to a point where we look back and say, "Oops, I wish I had orthoplasty anesthesia.
This is what I said. I told you right before we started here. I made my next LinkedIn post, and it's about what I've learned over the last 9 years in spinal deformity. And Bassel's exactly right. We should be moving forward. You should not be doing what you do 10 years ago. And that's one of my criticisms of some community spine surgeons I've seen is they come out of their training and they're very good, and they tend to keep a very similar practice for the next 25, 30 years, and then they retire. I don't like that. I don't think it's optimal. I look up to Phil Lucas, who I told you he retired from operating at 72 years old, and he trained on Harrington rods. And by the time he retired, he was doing C12 screws. He was doing laterals, X-lifts. He was doing everything. And that's the way it should be. You should continue to innovate throughout your career and learn the new techniques that work to advance the specialty.
Well, we owe it to patients, right?
100%.
Because that's at the end of the day. And it can be easy to forget it sometimes, or at least on the industry side of like, you get stuck in like, I'm trying to move this thing forward. And that's why I'm glad we're doing this podcast, because we had a lot of conversations between each other. You say you guys talk about spine all day long. We do the same thing, right? And like, we should be having these conversations because patients deserve to hear this, because it is so complex to understand. And having these conversations helps all of us be better. And it helps give patients a better idea, because it's about them at the end of the day. They deserve more. And like you said, in 10 years, hopefully they have more.
They will.
Absolutely. I mean, that's how medicine progresses. And if we talked about cancer today, and again, clinical trials are there, and a lot of patients just try it and it doesn't work out, and then they learn from there, and then they treat others better. I mean, the same thing in spine. Obviously Harrington was thought to be the best thing ever until somebody looked lateral. 20 years later. So yeah, I mean, we're going to continue to progress and toward the arthroplasty world.
You guys have been very gracious with your time, so I don't want to continue to take you. I know you guys have more things to do tonight. What I do want to do before we wrap, though, is where can people find you? Obviously, we're here at University Orthopedics, but what's the website they can find you? Where are you guys practicing at? What other locations? Where can people look you up?
Yeah, well, Bassel alluded to this earlier. We've been very fortunate to have a lot of patients now coming from around the country to see us. The beauty of the internet, it's pretty easy. I mean, my website's literally alendanielsmd.com, and that has all our information. But University Orthopedics is our primary practice site, despite Brown Orthopedics being our academic site. And so we're here in Providence. We see all around the regions and have a number of clinical sites. And we do a very good job of accommodating for patients that come from out of town or from a ways away.
Yeah, same. I mean, University Orthopedics website is there. I have my personal website as well. It's adult scoliosis surgery or spineandscoliosis-surgeon.com. If you just put our name up there,
you'll find us.
Google will take you,
Y'all are both very active on LinkedIn as well. So people should look you guys up there for some
Thanks
good conversations.
Thank you.
Thank you guys so much for sitting down with us. We appreciate it.
Really
Thanks,
appreciate
guys.
it. Thanks
for
a
coming
lot.
to Providence.